5 Navy SEALs were dying on 5 separate gurneys, and the only person in that trauma bay who understood why was the nurse everyone had already dismissed. Their vitals were collapsing on identical timelines, despite completely different injuries. The attending physician had already handed their cases to her, like a punishment, like busy work. She was nothing. What he didn't know, what nobody in that hospital knew, was that Claire Morgan had once kept men breathing in conditions that would have broken every doctor in that room. And in the next 4 minutes, she was about to prove it. Before the story goes any further, if you're new here, hit that subscribe button right now, because we drop stories like this every week, and you do not want to miss what's coming. Tap the like button if this already has your attention, and drop a comment telling me what city and country you're watching from. I want to see exactly how far this story has traveled. Now, let's go. The ambulance bay doors at Cascade Valley Medical Center in Bremerton, Washington blew open at 11:42 on a Tuesday night, and the sound they made was the kind that stopped people mid-sentence. 4 paramedics came through first, moving at the controlled sprint of people who knew better than to run in a trauma corridor. Behind them, 2 more units followed. Then 2 more after that. 5 gurneys in total, arriving in staggered sequence like a broken convoy, each one carrying a man who looked like he'd been wrung out and left to dry. Military build, close-cropped hair, the particular kind of stillness that wasn't rest. It was the body deciding whether to keep going. Claire Morgan caught it from the nurse's station before anyone else had even looked up. She was 41 minutes into a double shift, still wearing the dry erase marker stains from recalibrating a medication chart nobody else had noticed was wrong. Her scrubs were the kind of laundered too, many times blue that had gone slightly gray. Her hair was pulled back with the kind of efficiency that meant she hadn't thought about it once today. She had a cup of coffee she hadn't touched in 40 minutes sitting at the corner of the station, and when the first gurney came through, she set down the clipboard she was holding and stood up straight. Not because she was startled, because she was reading them already. The first man, late 30s, laceration across his left trapezius, one eye bandaged, was breathing at a rate that looked controlled but wasn't. His chest was moving with too much effort for the injury he'd presented with. The second, bigger across the chest and rolling in with a splint on his forearm, had pupils that weren't quite tracking the overhead lights correctly. The third was clammy in a way that wasn't consistent with the external blood loss showing on his thigh wrap. The fourth had the rigid posture of someone fighting pain in a location that wasn't the obvious one. The fifth was the quietest of all, which was the one that concerned her most. She moved out from behind the station without being called. Dr. Hale. She caught the attending before he reached the first gurney. I want to flag something before you triage. Dr. Warren Hale was 53 years old, the kind of surgeon whose confidence had calcified into certainty somewhere around his 3rd Chief of Staff award. He was tall in a way that he used architecturally, standing slightly above most conversations, angling his shoulders to suggest that whatever he was about to say was the last word. He glanced at Claire, the way people glance at a notification they've already decided isn't important. Morgan. He didn't slow down. I'm going to need you on intake documentation for units 3 through 5. Get ahead of it. I understand. But if you'll give me 30 seconds. 30 seconds is someone crashing on a gurney. He was already past her, already reaching for the chart the first paramedic was handing him, already slipping into the performance of command that the room expected. Documentation. Please. The please landed like a door closing. Claire didn't argue. She went to the 3rd gurney, pulled the rail down, and started the intake. But she wasn't just documenting. She was timing. She was watching. She was holding the sequence of what she'd seen at the ambulance bay doors against what she was seeing now, and something wasn't adding up, in a way that had nothing to do with paperwork. Senior resident Dr. Philip Garrett materialized at her left elbow with the particular energy of someone who had watched the exchange with Hale and decided to reinforce it. He gave you documentation for a reason, Garrett said, not quietly. Claire was checking the patient's skin temperature with the back of her hand while she wrote. You mind pulling his uniform jacket the left forearm seam, specifically? Morgan, his radial pulse is inconsistent with his BP presentation. I need to see if there's a secondary wound that wasn't caught in the field. Garrett picked up the chart instead of the jacket. His BP is within acceptable range for his injuries. His BP is within acceptable range for what we can see. She kept her voice level, kept writing, kept her hand on the patient's wrist. That's not the same thing. Garrett set the chart down and walked away. That was also a kind of answer. Across the trauma bay, Hale had the first two SEALs stabilized enough to start talking specifics with the Navy escort, who'd arrived alongside the ambulances, a compact, precise woman in uniform who had given her name once to the charge nurse and hadn't offered it again. Claire clocked the interaction without appearing to watch it. She noted the way the escort's eyes moved around the room, with the systematic quality of someone cataloging threat and resource at the same time. She noted that the escort's eyes stopped briefly on Claire, then moved on. The next 20 minutes were controlled chaos in the specific way that Cascade Valley ran it loud in clusters, precise at the center, everyone knowing their assigned lane and staying in it. Claire stayed in hers. She moved between gurneys 3, 4, and 5, completing intake documentation with a thoroughness that Hale would never read tonight and Garrett would never appreciate. And between each entry, she was building something in her mind that had nothing to do with forms. All 5 men were declining, not dramatically, not in ways that would trip a monitor alarm yet. But the trajectory was there if you knew what window to look through. And Claire had been looking through that particular window since she was 26 years old in a situation she no longer had clearance to discuss. The man on gurney 4, her current patient, mid-40s, a scar along his jaw that had been there long before tonight, opened his eyes while she was taking his blood pressure. He didn't say anything immediately. He looked at the ceiling, then at the equipment, then at her face, with the methodical quality of someone doing an assessment of their own. "You were at the intake bay," he said. His voice was the texture of gravel that had been rained on a few times. "I was." She finished the cuff. "Can you tell me where your pain is localized right now?" "Ribs." 3 sighed. "Is that where it was when they loaded you?" Pause. "It's moved." She wrote that down, kept her face neutral, kept her pen moving, but her pulse rate had just done something specific. "Has it intensified or spread?" "Spread." Another pause. "You're not the doctor." "No." He seemed to consider that for a moment, with more attention than most patients gave it. "You going to tell him?" "I'm going to try." She capped the pen. "Rest. Don't fight the monitors. Let them do their job." She crossed to Hale's position at the first gurney without giving herself time to rehearse it. "Dr. Hale." She kept her voice low. "I need 2 minutes. The 5 patients aren't presenting with 5 separate deterioration curves, tracking together." Hale was mid-instruction to a resident, and he finished the sentence before he acknowledged her. That was deliberate. She'd been in enough rooms to know the difference between a distraction and a statement of hierarchy. "Morgan." He handed the chart back to the resident. "These are 5 individuals with 5 discrete injury profiles. They are being treated accordingly. Their vitals are declining on nearly the same timeline despite the injuries being completely different in type and severity. Vitals fluctuate. That's why we have monitors. The monitors aren't catching it yet, catching it clinically." Something shifted in Hale's expression, not toward engagement, but away from patience. He turned to face her more fully, which was the kind of move that felt like attention, but was actually containment. "Completed intake for 3, 4, and 5. "Yes." "Then you've done your job." He picked up the chart again. "Leave the clinical interpretation to the people qualified to do it." People qualified. She'd heard that one in variations across 17 years of nursing. It still had a specific texture when it landed, like biting down on something that looked like food but wasn't. She went back to her station. She didn't sit down. Instead, she pulled up the intake vitals she'd documented, laid them out in a sequence on the workstation screen, and started comparing timestamps. The deterioration in the first patient had begun approximately 40 minutes post-exposure to whatever field condition had landed them here. The second patient's vitals showed a parallel dip, offset by roughly 8 minutes, consistent with a slightly later exposure window. Not a different injury type. The third patient's numbers were running 11 minutes behind the second. Sequential exposure. Same source. Different absorption timelines. She stared at the screen for long enough that the charge nurse, Dolores Tabb, drifted over and looked at it with her. "You seeing what I think you're seeing?" Dolores said. She was in her 50s and had the particular quality of longevity that came with watching a lot of attending physicians and learning not to say so out loud. "Possibly." Claire kept her voice down. "Were you here when they loaded in?" "Briefly." Dolores was quiet for a moment. "You smell anything off on the second unit when they came through?" Claire looked at her. "Not chemical exactly," Dolores said, carefully. "More like metallic. And burnt. Different than blood. Where are their uniforms? Bagged with personal effects in the secondary storage. Why? Claire was already moving. The secondary storage was 2 corridors over, a room that smelled of industrial plastic, and the specific stillness of things waiting to become evidence. The SEALs' field gear had been bagged by paramedics in the standard way, separate bags per patient, labeled stacked. Claire pulled on gloves, unzipped the first bag, and leaned close without touching the fabric directly. The smell was faint. She might have missed it if she hadn't been looking. She'd smelled it before. Not in this hospital. Not in any hospital. In a place with no walls and no ceiling, and the kind of decisions that didn't fit on any form she'd ever had to fill out since. She resealed the bag, pulled out her phone, wrote 4 words in a note and stared at them. Then she went back to the trauma floor and walked directly to Hale. The uniforms need to go to toxicology right now, she said. No preamble. I think there's a field contaminant, something aerosolized, based on the exposure pattern. That's why all 5 of them are on the same deterioration curve, despite different injuries. Hale stared at her for a long beat. Then something crossed his face that was close to amusement and farther from respect. Smelled their uniforms. Yes. You're a nurse, Morgan. I'm aware. And based on smelling their uniforms, you've developed a toxicology theory. Behind him, 2 residents had gone very still in the specific way of people who wanted to witness something without being associated with it. I'm not asking you to accept the theory, Claire said. I'm asking you to rule it out. Send the uniforms. 30-minute precaution. Sending field uniforms to toxicology without a physician order generates a paper trail that triggers a military oversight review. His voice was still measured, but there was something underneath it now that was less about medicine and more about management. That is not a decision made by nursing staff. Then make it as the physician. The stillness in the room changed quality. It went from observational to alert. Hale took 1 step closer. Not threatening positioning. You're out of your lane. Patient 4 has pain migration that suggests internal movement. Patient 2's pupils are slightly asymmetric. Patient 5 hasn't moved voluntarily since intake, which given his injury profile doesn't. Security. Hale didn't raise his voice. He didn't need to. He turned to the charge desk with the same energy he used to order a lab panel. I need someone to help Nurse Morgan return to her assigned station. She's interfering with active trauma protocol. Dolores at the charge desk picked up the phone. Claire looked at Hale for 1 full second. Patient 2 is about to crash, she said. Take her to the station, Hale said to the approaching security guard, a large man named Patterson, whose expression communicated that he wished he was somewhere else. Patterson put a hand lightly on Claire's elbow. She didn't pull away. She walked with him, because fighting a physical escort in a trauma corridor accomplished nothing except removing her from the situation entirely. She was 6 steps away from the trauma bay when she heard the alarm, not the steady alert of a monitor flagging a range. Sharp sequential scream of a patient in active deterioration, the kind that meant the numbers had stopped being a warning and started being a countdown. Patient 2. She stopped walking. Patterson's hand tightened slightly. Ma'am, she turned back. Across the trauma bay, Hale was already moving to the second gurney, already calling for the crash cart, already in the controlled velocity mode that good surgeons shifted into during emergencies. He was competent. She had never doubted that. What she doubted was whether competence without the right information was enough. Tension pneumothorax, she said, not loudly, more to Patterson than to the room. Sighed. The initial chest x-ray wouldn't have caught it if it was slow building. Patterson stared at her. He was not a medical professional, and he clearly had no idea what that meant, but something in the way she said it made him not move her further away. Across the room, a resident called out a pressure reading. Hale barked a correction. Another resident was already preparing something that Claire could see from where she stood was the wrong sequence. She could read the label from here, could do the math on what it would do in combination with what was already in the IV line. She didn't think about it. She moved past Patterson and was back in the trauma bay in 4 steps. She got to the resident's hand before the syringe made contact. Don't. Her grip was light but certain. Check the IV line. He has an existing vasopressor. What you're loading will tank his pressure inside 90 seconds. The resident young, startled, looking at her the way people looked at someone who'd appeared out of nowhere to grab their wrist, looked at Hale. Hale looked at the IV line. He looked at the syringe. A beat. Hold, he said. The resident held. Hale ran the combination himself, fast. In his head, she could see the calculation happening behind his eyes, see the exact moment when it resolved in a direction that matched what she'd said. Jaw set. Get me a needle thoracostomy tray, he said to the room. He didn't say she was right. He didn't say anything that acknowledged what had just happened. He moved to the patient, and the room moved with him. Claire stepped back to the perimeter of the bay. Patterson was still standing where she'd left him, looking profoundly uncertain about his responsibilities at this moment. She looked at the remaining 3 gurneys. Patient 5 still hadn't moved voluntarily. Patient 3's color was shifting in a way she didn't like. Patient 4, the man who'd spoken to her, had turned his head toward the activity at gurney 2 and was watching with eyes that tracked too well for someone with his alleged injury profile, which meant his injury profile wasn't complete, which meant something had been missed in the field or hadn't declared itself yet. She was thinking through the sequence exposure source timeline. What class of compound produced this kind of staggered systemic impact when patient 4 turned his head from the crash activity and looked at her directly, with recognition? Not the vague familiarity of a patient who'd seen his nurse twice in 20 minutes, but the specific focus of someone who had found the thing they were looking for. His right hand moved. He was connected to an IV line and a monitor and a blood pressure cuff, and moving wasn't something he should have been doing with this level of energy. But his right hand moved anyway, deliberate, controlled, and pushed back the edge of the blanket, covering his forearm. Then he looked at Claire's left wrist. She had a watch. She always wore it. It wasn't visible under the cuff of her scrub top, but sometimes when she was writing, when she was taking blood pressure, when she reached across a bed rail, the sleeve rode up just enough. He'd seen it, and his expression, for a fraction of a second, changed. He reached toward her, not in the grasping way of confused patients, not in the panicked way of people who were afraid, in the deliberate way of someone making a decision. Fingers closed lightly around her wrist, the left one right over the watch. Don't let them use the standard sequence, he said. His voice was quiet enough that only she heard it. His eyes were completely clear. She went still. The standard sequence. 2 words that shouldn't have meant anything to a trauma nurse in a civilian hospital on a Tuesday night in Bremerton, Washington. 2 words that did mean something, something specific, something that lived in a part of her memory she'd been very careful not to disturb for the better part of a decade. She looked at his face. She looked at his hand on her wrist. She looked at the watch. She had last heard those exact words in a specific order, in a specific kind of darkness, a very long time ago. I know, she said quietly. She gently removed his hand, set it back on the blanket, held eye contact for exactly 1 second longer than the clinical situation required. Then she turned to face the trauma bay, where 4 other men were running out of time, and where the physician in charge still didn't know that the nurse he'd tried to have escorted out of the room was the only person in this hospital who understood what was killing them. The man on gurney 4 closed his eyes again after that, the way people did when they'd said the thing they needed to say and didn't have the energy for anything beyond it. Claire stood at the edge of the trauma bay and let the noise of the room fill back in, around her Hale's voice directing the thoracostomy procedure, the sharp ping of monitors, controlled shuffle of 2 residents working a crash cart back into position. She let all of it land without reacting to it, because reacting required processing, and what she'd just heard from a half-conscious Navy SEAL in a civilian trauma bay was not something she was ready to process yet. Don't let them use the standard sequence. She had heard those exact words exactly once before in her life. Context had been different. The geography had been catastrophically different. The man who'd said it the first time had been someone she'd trusted completely, in a place where trust was a tactical calculation as much as anything emotional, and the sequence he'd warned her away from had been a medical protocol developed for one set of conditions that became lethal when those conditions changed. She had not heard that phrase in 9 years. She had not heard it from anyone outside of a circle of people whose names were attached to documents she was no longer cleared to read. She looked at the man on gurney 4. He was breathing. His chest was moving with more effort than it should have been, which fit the pattern she'd been tracking. The slow-building pressure she was, increasingly certain, had nothing to do with his documented injuries. His eyes were closed. His hand rested where she'd placed it, on the blanket, palm up, the way hands looked when the body decided to stop, pretending it wasn't exhausted. She made a decision. It wasn't a careful decision. She didn't have time for careful. She moved to the workstation at the side of the bay, pulled up the intake files for all 5 patients, and started typing. Documentation. A differential. Her own, running parallel to whatever the attending had formally ordered, laid out in the structure she'd been trained to use in conditions where you didn't have lab results, and you didn't have imaging, and you had to make the call on what you could observe with your hands and your eyes, and whatever part of your brain was still functional under pressure. 5 patients, 5 different primary injuries, identical deterioration slope when you lined up the timestamps, offset by windows of 8 to 12 minutes apiece. The offset was the key, not random fluctuation sequential, which meant sequential exposure to whatever the variable was, and if the exposure was sequential, it was environmental, not individual. Something they'd all move through in a line. Dolores appeared at her shoulder. She had the quiet way of moving that long shift nurses developed, the ability to arrive without announcing it. Hale's going to notice that terminal. Hale is mid-procedure. Claire kept typing. Who cleared the uniforms into secondary storage? Paramedic team. Why? What are you? Is there a field report with the transport paperwork? Extraction location. Environmental conditions. Anything about the site? Dolores was quiet for a moment. Then I can check. Please. Dolores moved away without asking for an explanation, which was one of the things Claire had always valued about her. She didn't need to understand the reasoning to assess whether the request was reasonable. That was a specific kind of intelligence that got underestimated constantly. Claire finished the differential, saved it under her login, and straightened up. Across the bay, Hale had completed the thoracostomy on patient 2. The monitor had stopped its urgent alarm and settled into something more sustainable. One of the residents, the younger one, the one whose syringe she'd redirected, was standing slightly apart from the group, looking at Claire with an expression she couldn't fully read from this distance. Not hostile, not grateful either. Uncertain, maybe. The expression of someone whose understanding of the situation had developed a crack. She walked to patient 5. He was the one she was most worried about, had been since intake. Early 40s, no visible major trauma, which meant either he'd been lucky or he'd been hurt somewhere that wasn't showing yet. His skin had the wrong kind of stillness to it, not the stillness of rest, but the stillness of a body that had redirected all its resources toward something internal and had nothing left over for surface signals. She pulled a penlight. His pupils responded, but slowly. Nexismits. The lag was small enough that it wouldn't have tripped anyone's alarm on a busy night, but she'd been watching his baseline since he arrived, and the lag had increased. She checked his hands. The skin at his fingertips had a faint dusky tone that could have been lighting, could have been nothing, could have been the early peripheral vasoconstriction of a system under systemic stress. She checked his breath sounds. Left side was diminished, not absent, diminished. The difference between those two things was the difference between a problem that had arrived and a problem that was arriving. She needed imaging on this patient 20 minutes ago. She went back to Hale. She knew what the experience of this approach felt like. From his side, a nurse materializing at his peripheral vision for the 3rd time in 40 minutes, each time with something he didn't want to hear. She knew it was wearing. She also knew that patient 5's left lung was in the process of deciding something, and if it decided wrong, there wasn't going to be an opportunity to revisit the conversation. Patient 5 needs a chest CT, she said. Hale had his back to her. He finished the notation he was making before he turned. Patient 5 is stable. His breath sounds are diminished left side. There's been a progressive lag in his pupillary response since I first checked him at intake. And his peripheral coloring, his O2 sat, is 94. His O2 sat will drop after the compensation fails. Hale turned fully now. He had the look of a man who had run out of patience in a controlled way, not explosively, but with a finality that he clearly expected would end the conversation. Morgan, I have 5 critical patients, a trauma bay that is at capacity, and 2 residents who need direction. I do not have time to chase nursing intuition on a stable patient. Not intuition. I have a differential pulled up on workstation 3. Give me 2 minutes to walk you through. I don't review informal differentials written by nursing staff. He said it the way you stated a policy, not the way you made an argument. Like it was already settled. Like the category of things she'd done was enough to dismiss the content of it. Behind him, Resident Garrett had materialized with the particular timing that suggested he'd been listening and wanted Hale to know he agreed. She's been at 3 different patient stations. Without a direct assignment, Garrett said. Helpfully. Pointedly. And she left her assigned documentation post twice. Hale looked at Garrett. Something passed between them that had the texture of confirmation, not of a fact, but of a stance. Morgan. Hale turned back. You've been redirected twice tonight. A third instance is a conduct issue, not a clinical disagreement. I want you on documentation for the remainder of this shift. If you have observations about patient status, you document them in the standard notes field, and they will be reviewed in morning handoff. Morning handoff. Patient 5 was not a morning handoff situation, but she could see from the set of Hale's shoulders that this was a wall, not a door, and pushing on it harder wasn't going to change its structural nature. What it would do was accelerate the sequence she'd been trying to avoid being formally removed from the floor in a way that left her completely unable to intervene. She went back to the documentation station. She documented everything, not just the standard intake information. Everything. Timestamp of every vital sign she'd observed. The specific language of every interaction with Hale. The differential she'd built, in full, with the clinical reasoning behind each element. She documented the smell from the uniforms, describing it in precise sensory terms, and her assessment of what class of contaminant could produce that olfactory profile. She documented patient 4's deteriorating breath sounds, patient 5's progressive pupillary lag, patient 3's color changes. She documented the timeline offset across all 5 patients with the timestamps she'd pulled. She built a record, not for morning handoff, for something else. Dolores came back while she was writing. Transport paperwork. She slid a folded set of pages onto the desk beside Claire's keyboard. Field notation at the bottom of page 2. Paramedic noted an unusual smell at the extraction site, described it as chemical, metallic. Claire opened the pages. The notation was brief 4 lines, the kind of thing written quickly by someone whose primary job was moving people, not analyzing environments. But it was there. Site, environment, possible industrial exposure, chemical odor reported by team lead at extraction. Recommend flagging for toxicology review. Recommend flagging for toxicology review. It had been flagged on the transport paperwork, which meant it had arrived at this hospital as a recommendation, and somewhere between the ambulance bay and the trauma floor, someone had not acted on it. She looked at the timestamp on the notation. It had been written before the patients arrived, before Hale had even seen them. She looked at the intake documentation. No toxicology flag, no mention of the field notation, no referral generated. She set the pages down flat on the desk and looked at them for a moment. Then she picked up the phone. She called the hospital's toxicology department directly, bypassing the physician referral chain, and requested an urgent consult on 5 trauma patients with possible environmental exposure. The toxicologist on call, a soft-voiced woman named Dr. Avery Nkosi, who sounded like she'd been asleep and was now very much not asked for a physician order number. There isn't one yet, Claire said. I'm flagging a nursing concern under the environmental exposure protocol. The transport paperwork includes a field notation recommending the referral. I need someone to look at it. A pause. Who's the attending? Dr. Hale. Another pause longer. I'll need him to confirm the consult. Understand. She kept her voice steady. In the meantime, can I walk you through the clinical picture I'm seeing? For when you have that conversation with him. Nkosi was quiet for a moment. Then go ahead. Claire talked for 7 minutes. She laid out the timeline offset, the common deterioration pattern, the field notation, the olfactory observation, the way each patient's decline was tracking against an exposure window rather than an injury window. She used precise language and didn't editorialize, and didn't ask Nkosi to take a position. She just gave her the picture. When she finished, Nkosi said, I'll call Dr. Hale directly. Thank you. She hung up and looked at the trauma bay. Patient 2 had stabilized. Hale was at patient 1 now, which was the right priority. Patient 3 was being managed by the younger resident, the one with the uncertain expression, and from where Claire sat, he was doing it carefully, which was something. Patient 4 was still. Patient 5 had not moved. Pulled up the oxygen system status on the secondary workstation. It was something she'd been meaning to check since early in the shift, before the SEALs had arrived, because there had been a pressure irregularity flagged in the maintenance log that nobody had formally signed off on. In a normal night, it was a background concern. Tonight, it was climbing the list. The oxygen system fed the entire trauma wing from a central manifold. The pressure had been dropping slowly, not enough to trigger an automatic alert, but enough to show a trend when you graphed the last 4 hours of readings, side by side. The trend was toward insufficient delivery pressure. In a patient requiring sustained oxygen support, insufficient delivery pressure didn't look like sudden failure. It looked like gradual desaturation. It looked like a patient who was fighting harder and harder to do what the supplemental oxygen was supposed to be doing for them. It looked like what was already beginning to happen to patient 5, called maintenance. Got a voicemail, left a specific message about the manifold pressure, and the patient population currently in trauma and the urgency she needed attached to a callback. Then she stood up. Patient 3's color had shifted again. The resident managing him had his back turned, adjusting an IV line, and hadn't looked at his patient's face in approximately 3 minutes, which was about 2.5 minutes longer than this particular moment warranted. Crossed the bay and stood beside the gurney. The patient, late 30s, the one with the splinted forearm, had gone from the grayish pallor of blood loss to something with a slightly different undertone. Not gray, ashen, but with a quality that suggested the blood wasn't just low at the surface, it was retreating. Internal, she put her hand on his abdomen. His face changed, not dramatically. A tightening around the eyes that was involuntary. That wasn't the wince of someone responding to a clinical exam, but the wince of someone who had been holding something at bay and just felt their hold slip. She lifted her hand and looked at the resident. His name was Tanner. She'd worked with him twice before. He was green in the way of people who were technically competent and experientially narrow, which was not a character flaw, but was a real limitation in a room like this one. Tanner. She kept her voice at a register that wouldn't carry to Hale. His abdomen is involuntarily guarding. I think he's bleeding internally. Tanner looked at her, then at his patient. His BP is still compensating. It'll hold until it doesn't. She kept her eyes on Tanner. You need to tell Hale. I just checked him 15 minutes ago. I know. Tell him anyway. Tanner hesitated. He was doing the calculation that junior residents did constantly, the calculation between what they were observing and what the attending had already decided, between trusting their own read and deferring to the hierarchy that would ultimately grade their performance. She understood the calculation. She'd watched it play out 100 times. She hated what it cost, every time. You can tell him your assessment and mine together, she said. You don't have to lead with me. Something in Tanner's expression shifted. He went to Hale. She watched the conversation from across the bay. Tanner was controlled, specific, professional about it. Hale listened, and she could see from his body language, the moment he ran the clinical scenario against what Tanner was describing, and came up short on an easy dismissal. He moved to patient 3. He palpated the abdomen. Face didn't change, but his hands told a different story. He pressed the call button for the OR without looking up. Patient 3 was going to surgery. That was good. That was the right call. It was also the call that left Hale with one less resident in the trauma bay, one more patient in active surgical prep, and significantly less bandwidth to manage the 4 remaining SEALs. The math was changing. She was watching how it was changing when her phone buzzed. She looked at the screen. Dr. Nkosi. She'd texted rather than called, which meant she was being careful about being overheard. Spoke with Hale. He declined the consult. Said the environmental theory was speculative nursing concern, not a physician-assessed risk. Documented his refusal. Thought you should know. Claire read the text twice. Documented his refusal. Nkosi had put it in writing. That was a specific kind of professional decision, one that distanced yourself from an outcome while also creating a record that could be examined later. It meant Nkosi thought Hale was wrong. It meant Nkosi wasn't willing to carry the consequence if that wrongness produced a result. She typed back, "Thank you. Can you begin informal review of exposure profiles consistent with field contaminants? Not a formal consult. Background work." A pause. "Then I can do that." She put the phone away. Patient 4 moved, not a dramatic movement. His right hand lifted from the blanket again and made a small, deliberate gesture, one finger extended, pointing vaguely toward the wall of the trauma bay where the oxygen equipment was mounted. She crossed to him quickly, because at this stage of whatever was happening to his system, a deliberate gesture was spending something he didn't have a lot of. "I'm here," she said quietly. System. His voice was a fraction of what it had been earlier. Pressure. She looked at the oxygen manifold readout on the wall panel. Pressure had dropped another 4 points while she'd been working. I know, she said. I flagged it. Faster. His eyes found hers. They were still clear, which almost made it worse. It'll go faster. She looked at the panel. Looked at the 5 patients in the bay. All of them on supplemental O2. All of them fighting systems that had been compromised by something they'd breathed in a field location that nobody in this hospital had fully investigated. He was right. Whatever was happening to the manifold pressure was going to accelerate against the demand being put on the system right now. The drop had been gradual for 4 hours. With 5 high-demand patients on the line, gradual wasn't going to be the operative word much longer. She called maintenance again. This time, someone answered. She explained the situation in terms that were specific enough to be unarguable and urgent enough that the maintenance tech on the other end stopped trying to run through a troubleshooting protocol and said he'd be there in 8 minutes. 8 minutes. She looked at the manifold. She looked at patient 5, who was running the poorest numbers in the bay and who was most dependent on that system functioning correctly. She was working through the contingency math manual resuscitators, portable oxygen units, what she could pull from adjacent supply rooms to bridge a gap when the trauma bay doors opened. Not paramedics this time. Not a crash cart. Not maintenance. Not Hale returning from a consult. A man and a woman, both in military dress uniform. Behind them, 2 people in civilian clothes who carried themselves with the specific posture of people who operated outside of standard institutional hierarchies. The man in uniform was compact, somewhere in his late 40s, with the kind of steadiness that came from having been in rooms like this one many times, and knowing how to wait until the room understood it needed to defer to him. He spoke to the charge desk. Dolores' expression changed in a specific way that Claire could read from across the room. Not alarmed. Recalibrating. The man produced identification. Dolores looked at it, looked at him, looked at the trauma bay. Then she looked at Claire. Not at Hale. Not at Garrett, who was standing closer to the doors. Not at the senior physician in the room. At Claire. And Claire felt something settle in her chest that was not comfort, exactly, but was the particular internal stillness of a moment you had been moving toward for a long time, without knowing you were moving toward it. The man in uniform crossed the trauma bay with his identification still in his hand and stopped in front of her. I'm looking for the nurse who flagged the environmental concern, he said. Hale, who had re-entered the bay from the surgical prep corridor, heard that sentence and turned around. I'm the attending physician, Hale said, moving toward them with the authority of someone who was used to that phrase being. Whatever you need to discuss about these patients, you discuss with me. The man in uniform looked at Hale with a neutrality that was not rudeness but was also not deference. I need to speak with the nurse who filed the observation report. There is no formal observation report, Hale said. There's an informal notation by a nursing staff member who has been redirected twice tonight for exceeding her scope of practice. The man looked at Claire. You're Morgan? Yes, she said. You contacted the toxicology department at 2217. I did. And you documented a timeline offset across 5 patients suggesting sequential environmental exposure? She could feel Hale's stillness from where she stood. Quality of it had changed. Yes. The man nodded once. He turned to the woman who'd come in with him and said something brief that Claire didn't catch. Then he turned back to the room at large. I'm Commander Darren Solis, Naval Special Warfare Command. These 5 men are from an active operational unit, and they were extracted from a site flagged for potential chemical exposure 37 minutes before they arrived here. His voice was even and clear and carried to every corner of the bay without him raising it. That flag was included in the transport documentation. I'm here to confirm whether it was acted on. The silence that followed was the kind that rooms made when they understood that the ground had just shifted. Hale said nothing. Garrett said nothing. Solis looked at the transport paperwork that Claire had left open on the documentation desk. He walked to it, picked it up. Read the notation at the bottom of page 2. His expression didn't change, but something behind his eyes did something that processed and filed and arrived at a conclusion. He kept entirely to himself. He set the paperwork down. He looked at Hale. Was a toxicology consult ordered on these patients? Hale's jaw moved. The clinical presentation did not warrant. Consult ordered. A pause that lasted 1 second longer than it should have. No. Solis looked at the woman in uniform beside him. She was already writing. Then he looked at the two civilians, who had moved to separate positions along the perimeter of the bay in the way that people moved when they were preparing to observe rather than participate. Then he looked at Claire. "Walk me through what you found," he said. And behind him, standing at the edge of the trauma bay, where the overhead lights caught the polished surface of his chief of staff credentials, Dr. Warren Hale stood completely still and watched a Navy commander ask a nurse to explain what his own department had failed to do. Claire didn't look at Hale when Solis asked the question. She looked at the 5 gurneys because that was where the problem lived, and that was where her attention needed to stay. "Start with the timeline," she said. "Not the injuries. Timeline." Solis nodded once. He had the quality of someone who understood that the fastest path through a situation was to let the competent person in the room do what they were going to do and get out of their way. She walked him through it the way she'd walked Nkosi through it on the phone, but faster and with more precision, because this man didn't need her to be careful with the clinical language. He understood the language. She could see it in the way his eyes moved, tracking her reasoning, not her words. "Sequential offset of 8 to 12 minutes across all 5 patients," she said. "That's not 5 separate deterioration curves from 5 separate injuries. That's one exposure event with a moving exposure window. They moved through something in a line. First man in had the longest exposure. Last man in had the shortest. The gap matches the spread in their deterioration timing. What's the contaminant profile? I don't know specifically, but the field notation says metallic and chemical. The olfactory description in the transport notes matches a class of organometallic compound, something that gets absorbed transdermally and through inhalation simultaneously. That's why the surface injuries masked it. They came in bleeding and fractured, and that's what we treated. The internal timeline was running underneath." Solis turned to the woman beside him. "Get Nkosi up here now." The woman was already on her phone. Hale stepped forward. "Commander, the clinical management of these patients is the responsibility of this department. I have to ask that you— I understand your position, Doctor." Solis didn't raise his voice. "I need you to stand by for 10 minutes while I get a complete picture." It was said politely. It was not said as a request. Hale stood by. Claire moved back to patient 5 while Solis worked the room. She needed to check the O2 levels again, because the maintenance tech was still 4 minutes out, and 4 minutes was not a number she was comfortable with, given the manifold trend. She pulled the portable pulse oximeter and clipped it to patient 5's finger, watching the readings settle. 91. Down from 94 when she'd last checked. She looked at the manifold panel on the wall. The pressure indicator had dropped another 2 points. She did the math on the rate of decline against the current patient demand and arrived at a number she didn't like. She went to the supply corridor off the trauma bay and pulled 2 portable oxygen units from the emergency cache, the kind with their own self-contained tanks. She brought them back to patient 5 and patient 4, who was the next most at risk based on his deteriorating breath sounds. She switched them to portable supply without making a production of it, disconnecting them from the central manifold and connecting to the portables in movements that were quiet and fast and drew exactly as much attention as she wanted them to, which was none. Patient 4's eyes opened when she adjusted his line. He said, "Manage," she said, "you're on portable. Don't move." He looked at the portable unit. "How many do you have?" "Enough." She wasn't entirely sure that was true. "Rest. Pull the others too." "I know." She straightened up and looked at the remaining 3 patients. 2 of them were at lower acute risk than 4 and 5, but lower acute risk was a relative term tonight. "I will." She went back to the supply corridor. Dolores was already there. "Pulled 2 more," Dolores said, holding them up. "I heard you the first time." There was something almost funny about it, in the way things were almost funny when you were too focused on not letting people die to actually laugh. Claire took one of the units, and they split up Dolores to patient 1, Claire to patient 3, who was back from surgical prep and freshly stabilized, and did not need the additional complication of a failing oxygen delivery system on top of everything else. The maintenance tech arrived while she was connecting patient 3's line. He was young, wearing a vest with a Cascade Valley Engineering Services logo, and he went to the manifold panel with the focused energy of someone who'd been told this was urgent and believed it. He looked at the readings, pulled a diagnostic tablet from his vest, and started running pressure checks on the line segments. 2 minutes later, he found the fault. A regulator valve in the secondary supply junction had developed a partial seal failure, not a sudden break. a slow degradation that had been progressing for approximately 6 hours. Under normal patient load, it would have continued degrading slowly and probably triggered an automated alert before it reached critical failure. Under the demand currently being placed on the system, it had accelerated. How long to fix it? Claire asked. Swap the regulator. 20 minutes if I have the part. Do you have the part? He checked his kit. Yeah. Then you have 15, she said, and moved away. Solis had pulled up her documentation on the workstation and was reading through it with one of the civilians while the woman in uniform, her name badge, said Reyes managed a separate phone call with an economy of words that suggested she was talking to someone who didn't need much context. Hale was standing near the far wall in the specific posture of a person who was present and had been asked to wait, and was finding that experience genuinely difficult. Garrett had disappeared, which Claire noted and filed. Nkosi arrived 12 minutes after Solis's call. She was a compact woman with natural hair pulled back under a scrub cap that she'd clearly grabbed on the way out of whatever she'd been doing, and she came through the trauma bay doors, reading the message thread on her phone rather than watching where she was going, which should have been a liability, but she navigated around a gurney without looking up. So clearly she had some practice. She and Claire made eye contact across the room. Nkosi nodded. A small, specific nod that communicated several things simultaneously. I read your summary. I think you're right. I documented Hale's refusal. I'm here, now. She went straight to the uniforms. Solis met her at the storage bay door, and they spoke briefly. Nkosi pulled on a respirator before she entered, which was the correct decision, and which also communicated her read of the situation, without her having to say it. You didn't put on a respirator to check uniforms you thought were clean. Claire stood in the center of the trauma bay and looked at all 5 patients at once. Patient 2 was stable, the thoracostomy had held, and his numbers were consistent. Patient 1 was the best of the group, had been since intake, and that fit the exposure model, because if you were first in the line, you also spent the least time in whatever environment preceded the extraction. Patient 3 was post-surgical, stable but fragile. Patient 4 was on portable O2, awake, watching the room with the careful attention of someone who was in pain and managing it deliberately rather than being overwhelmed by it. 5 was on portable O2, numbers holding at 91, which was not good but was not falling further, which meant the portable switch had done what she needed it to do. The maintenance tech was elbow deep in the manifold housing with a regulator wrench. The room was running on parallel tracks of crisis, the medical, the mechanical, the institutional, and each track was moving fast enough that losing attention on any one of them for too long meant losing ground. She went to Tanner. He was at the documentation station, entering notes with the careful speed of someone who understood that tonight's documentation was going to be examined very thoroughly and wanted it to be accurate. Tanner. She kept her voice low. Patient 4's breath sounds. Has anyone done a follow-up auscultation since intake? Stop typing. Garrett was supposed to. He looked at the bay. Where is Garrett? She'd been wondering the same thing. Find him, and do the auscultation yourself before he gets back. Tanner went. Nkosi came out of the storage bay 12 minutes after she'd entered. She pulled the respirator down to her chin and walked directly to Solis. Spoke quietly, but Claire was close enough to hear the structure of it, even if she couldn't catch every word. Confirmatory, specific, and carrying the particular quality of a clinical professional who had just found something she expected to find, and was not pleased about it. Solis listened without interrupting. Then he turned and looked at Hale. It was not a dramatic look. It was the look of a person who has arrived at the end of an assessment process. The uniforms show trace contamination consistent with an organometallic aerosol compound used in specific types of controlled demolition. It's not a common industrial exposure. It's on a list. He let that land for a moment. It requires a specific treatment protocol, not the standard sequence for organometallic poisoning, a modified version, because the standard sequence has a known interaction with one of the vasopressors your patients have been receiving. The room did the thing rooms did when something critical had been said. It didn't go louder, it went quieter, but the quality of the quiet was different. Alert processing, Hale said. What interaction? Cardiac suppression. Progressive. The standard protocol accelerates the toxin's effect on the myocardium in patients who've already received vasopressor support. Solis looked at Claire. You told patient 4 not to let anyone use the standard sequence. Told me, Claire said. Everyone in the room looked at her. Kept her eyes on patient 4. He had turned his head toward the conversation, and his expression was the expression of someone who had been waiting for this specific moment and was not entirely sure how to feel about it now that it had arrived. He recognized my watch, she said. It's a military issue watch, from a specific period and a specific unit. He knew what it meant. She paused. He's been in a room with me before. Not this room. Solus was very still. Who are you, Nurse Morgan? She looked at him. I'm the nurse who was asked to handle intake documentation. It wasn't evasion. It was precision. But it didn't land as precision. It landed as something else. Something that made Solus's expression shift, in the way expression shifted when someone received new information about the shape of the problem they were in. Morgan. His voice had changed register slightly. For this hospital. She held his gaze. She had spent 9 years being very careful about this. She had spent 9 years building a life in which the answer to that question was not the first thing anyone knew about her. She was standing in a trauma bay at midnight with 5 men whose lives were currently balanced on what happened in the next 20 minutes, and the version of this moment she had constructed in her mind over the years, careful, private, on her own terms, was not available anymore. Special Operations Combat Medic, she said. Captain. Separated from service 9 years ago. Tanner, who had returned from his auscultation and was standing 6 feet away, went completely still. One of the civilians near the perimeter made a small notation. Reyes, on her phone, paused mid-sentence and looked up. Hale, across the room, said nothing, but his face did something. It was not a large movement. It was the particular micro-expression of a person whose entire interpretive framework for a situation has just been invalidated and who has not yet had time to construct a replacement. Claire had seen it before, on other faces, in other rooms, but never with quite this specific configuration, because this time the framework being dismantled was the one that had categorized her as less than. That had treated her warnings as nursing intuition, and her observations as overreach, and her presence as an inconvenience. She didn't let herself feel it. Not yet. There was too much still in motion. The modified protocol, she said to Solus. Do you have it? Reyes. He turned to the woman with the phone. Reyes was already moving. She went to her bag a hard-sided case that had the look of something built for secure transport rather than general use, and produced a sealed folder. She handed it to Solus, who opened it and laid the contents on the documentation desk. Claire looked at the protocol. It was formatted differently from standard clinical documentation, tighter, more procedural, with decision points marked in a specific color sequence she recognized from training materials she had not seen in 9 years. She read it in the way she'd been trained to read it, quickly and completely, running the procedures against the patient profiles July had been building in her head since intake. Patient 2 has already received vasopressors, she said, reading and talking simultaneously. We need to check the cumulative dose against this interaction threshold. She looked up at Tanner. Pull his medication log. Everything since arrival. Tanner pulled it. She read the protocol. Read the log. Did the math. He's under the threshold, she said. Barely. We need to stop the vasopressor line now and shift to the modified supportive sequence before the next scheduled dose. Solus looked at Hale, not with challenge, with the practical requirement of institutional process. Dr. Hale came to the desk. He read the protocol. He read the medication log. His jaw moved. Stop the vasopressor on patient 2, he said to Tanner. Shift to fluid support, pending the modified sequence. Tanner moved. Patient 4, Claire said. He needs the pulmonary support adjusted. His breath sounds are diminishing, and the protocol shows the compound affects surfactant production. That's why it presents like a slow pneumothorax, without the pressure differential you'd expect. He needs a different support structure than what we've been running. Hale was still at the desk reading. What does the protocol specify? She showed him. He looked at it for 3 seconds. Then he turned to the bay. I need a respiratory therapist in here. He looked at Claire. Stay with the protocol. Walk me through each patient. It was the first time he had said those words to her. She moved to patient 1 and started from the beginning. The next 40 minutes were the kind of work that didn't look dramatic from the outside. No crashes, no code calls, no running. What it looked like from the outside was 5 nurses and 2 physicians and a respiratory therapist moving with controlled precision between 5 gurneys, adjusting lines, recalculating doses, shifting support modalities based on a protocol that nobody in this hospital had seen before tonight. What it felt like from the inside was the specific, exhausting. High-stakes focus of managing 5 simultaneous situations that each had their own momentum and their own risk points and their own narrow windows in which the right intervention at the right time made the difference between a patient who stabilized and one who didn't. The maintenance tech finished the manifold repair at the 40-minute mark and gave Claire a thumbs up from across the room. She nodded and shifted patients 1 and 2 back to central oxygen supply while keeping 4 and 5 on portable for another 20 minutes as a buffer. Nkosi had set up a field toxicology station at the corner of the bay, running analysis on the uniform samples to build a more specific contaminant profile that she could use to refine the treatment sequencing. She worked fast and communicated results to Claire in clipped, specific bursts confirmation of the organometallic class, the probable compound subfamily, the expected half-life in the patient's systems given their absorption windows. Claire took each piece of information and ran it against the protocol and against her read of each patient's current state, adjusting where the data told her to adjust. Patient 4 was the hardest. His lung function was the most compromised, and the compound's effect on surfactant production was fighting what the respiratory therapist was trying to do, so it became an iterative process: support, assess, adjust, port again, each cycle trying to stay ahead of the compound's timeline while not overloading a system that was already working at reduced capacity. Twice she made a call that the respiratory therapist questioned. Both times she walked through the reasoning. Both times the therapist ran the numbers, paused, and deferred. She didn't feel triumphant about it. She felt focused. At the 90-minute mark, all 5 patients had stabilized, not recovered, stabilized. There was a significant difference between those two things, and the distinction mattered because the compound's full clearance would take days, and the patients would need monitoring and modified support throughout that period. Acute danger, the cascading deterioration she'd seen beginning at intake, and that had been accelerating toward a series of possible cardiac events, had been interrupted. She stood at patient 5's gurney and watched the monitor numbers hold. 93, 94, steady. She let out a breath. It was not a dramatic breath. It was the functional kind, the kind that came when a body that had been running at high alert for 90 minutes was given half a second in which nothing immediately required its attention. Solus came to stand beside her. He was quiet for a moment, looking at patient 5's numbers. "How long have you been here?" he asked. "At this hospital." 3 years. "And before that, Harborview. Before that, a surgical unit in Tacoma. Before the OSD. Transition period." He nodded. He knew what transition period meant, said in that specific tone, with that specific lack of elaboration. "The man on gurney 4, he said. Sergeant Dale Reese. He served in the same operational theater as your last deployment." She looked at patient 4, Reese. She hadn't known his name until this moment. She looked at his face and tried to place it against the faces. She'd kept carefully behind a wall for 9 years, and found that she couldn't do it. Precisely couldn't find the exact moment, the exact context, the exact version of the past where their paths had intersected. But he'd known her watch, and he'd known the phrase, and that was enough to tell her the rest was true, even if she couldn't pinpoint it. "I didn't know him by name," she said. "He knew you by something else." Solus was quiet for a moment. There was an extraction. "Approximately 11 years ago. Field medic maintained viable patient status on 4 wounded personnel under sustained hostile conditions for approximately 40 minutes while awaiting extraction. No physician present, no standard equipment. The field medic improvised and held the line." He paused. "That record is classified. Has been since it was written." Claire said nothing. "Reese was one of the 4, Solus said. Kept her eyes on the monitor. 94. Steady. "He recognized me," she said. "Not a question. He told his commanding officer before they loaded out that if they were going to Cascade Valley, there was someone there he wanted managing his care." Solus's voice was even. "We didn't make the connection until we arrived and saw your name tag." She looked at Solus. "He requested me specifically," he said, and I'm quoting, "find the nurse with the old watch. She knows what she's doing." The monitor beside them pinged softly. She looked at it, read the number, looked away. She was not going to do the thing where the moment overwhelmed her. Not here, not now, not in the middle of a trauma bay, with 5 patients still in active monitoring and a toxicology protocol that needed 2 more hours of oversight. She was going to process this at a time, and in a location where processing was appropriate. but she let herself acknowledge it, just for a second. Then she turned back to the room, because there was still too much left to manage. Hale was at the documentation station. He was reading the intake files, not the official intake, the one Claire had built on the secondary workstation, the one with the full differential and the time-stamped observations and the record of every interaction she'd had with him tonight. He was reading it the way people read things when they were looking for a different interpretation and not finding one. Garrett had reappeared from wherever he'd been. He was standing near the bay entrance with the specific quality of someone who'd arrived back to a situation that had changed in his absence and was trying to read how much it had changed. Claire assessed him briefly and looked away. There would be time for that. Nkosi was breaking down her field station, organizing her analysis results into a formal report structure. She glanced at Claire as she worked, and their eyes met again. This time the nod was different, less confirmatory, and more like the specific acknowledgement that passed between two people who had both done the thing that needed doing in a situation that made it unnecessarily difficult. Tanner was at patient 2's station, monitoring the vasopressor transition. He was doing it with the careful attention of someone who understood that the last 2 hours had been a clinic in something he hadn't been taught in his residency program. Solis was speaking quietly with Reyes. Claire caught fragments: formal review, transport documentation, chain of referral, the language of institutional consequence beginning to organize itself into structure. She went back to patient 5. His numbers had ticked up to 95. She adjusted his positioning slightly, tilted the head of the bed by 3 degrees to optimize the lung expansion on the left side. Small change. The kind of change that didn't look like anything, but that moved a number in the right direction. She was standing there, watching the monitor, when patient 4 spoke. Morgan. She crossed to him. He was looking at the ceiling, then at her with the particular economy of a person who was conserving effort for the things that required language. They know now? She understood what he was asking. Yes. His jaw shifted. Not quite a nod. The ghost of one. Was it enough? She thought about that. Thought about all 5 monitors, all 5 sets of numbers, the manifold pressure now stable at the correct level, Nkosi's field analysis in progress, the modified protocol running across 5 adjusted treatment plans. Ask me in 48 hours, she said. Something moved across his face. It might have been the beginning of a smile. It was too worn out to complete the journey. She was straightening up from his gurney when Solis crossed the room with a tablet in his hand, and his expression had changed in a way that made her stop. He turned the tablet toward her. It was a document. She looked at the header, read the classification marker she hadn't seen in 9 years, and felt something very specific and very cold move through the center of her chest. This came in while we were working, Solis said. Triggered by the flag on the compound. Automatic protocol when specific classified contaminants are identified in a civilian medical context. He paused. It's a request for identity verification on the treating medical personnel. She looked at the document. Her name was already there. Her old name. The full one, the rank and the unit designation and the record number she'd had before she left the service and became Claire Morgan, civilian trauma nurse at Cascade Valley Medical Center in Bremerton, Washington. This is going to open the sealed record, Solis said. She looked at him. Everything, he said quietly. The classified extraction. The field commendation that was sealed at your request. The reason you left. All of it is going to come out of seal the moment this verification processes, and it will process in approximately. He checked his watch. 22 minutes. Claire looked at the document. She looked at the trauma bay at Hale, still at the workstation. Garrett, near the door. At Tanner and the respiratory therapist in Dolores, and the 2 civilians who were still making notations near the perimeter. At Reese on his gurney, eyes half closed. At patient 5 with his numbers holding at 95. She had spent 9 years building a specific kind of anonymity. Not hiding, she hadn't done anything that required hiding. But not announcing either. Not using what she'd been as a credential. Not trading on it. Not asking the rooms she walked into to treat her differently because of it. She'd wanted to be a nurse and have that be enough. She'd wanted to be good at the work and have the work speak for itself. In 22 minutes, every person in this room was going to know exactly who she was, and she couldn't decide in this moment whether that felt like losing something or finally being allowed to stop carrying it. Solis was watching her. I can try to delay the processing, he said. Stop it. But I don't, she said. He waited. Don't delay it. She handed the tablet back. Let it process. She turned back to the bay. She had 22 minutes of work still to do before the world changed, and she was going to use every one of them. She was at patient 3's station, reviewing his post-surgical numbers against the modified protocol's guidance for patients who'd undergone emergency intervention during active exposure, when she heard Hale speak behind her. His voice was different. Not the measured architectural certainty it had been carrying all night. Something had gone out of it, not collapsed, reduced. The way a structure sounds when you've removed a load-bearing assumption. Morgan. He was across the room, still at the workstation, not moving toward her, staying where he was, which was a choice. This differential you built. She didn't turn around. What about it? The exposure timeline, the offset calculation. A pause. This is what you were trying to tell me at 22:10. She finished what she was doing with patient 3's chart, looked at his numbers, made a notation. Yes, she said. The room was quiet in the way rooms got when everyone in them was pretending not to listen. If I had ordered the toxicology consult at 22:10, Hale said, and his voice had the specific quality of a person doing arithmetic they don't want to finish. The modified protocol would have been in use approximately 70 minutes earlier. She turned around. He was looking at her. Not with the managed authority of a senior physician dealing with a subordinate, with the straight, unadorned expression of a man who had arrived at a fact he didn't know what to do with yet. Yes, she said again. 70 minutes. She didn't say what 70 minutes meant against the compound's interaction with the vasopressors. She didn't say what 70 minutes meant for the cardiac risk windows on patients 2 and 4. She didn't have to. He was the attending. He knew how to run that math. She watched him run it. His expression didn't break, but it reorganized. She was still holding his gaze when, from the direction of the trauma bay entrance, one of the civilians cleared their throat and held up his phone in the direction of Commander Solis. Commander, he said. Verification processed early. Server must have had a backlog clearing. Solis looked at Claire. She looked at the phone. On the screen, through the distance and the angle, she couldn't read the document. But she could see the header color, the classification band, and she could see Hale, in her peripheral vision, turning toward the sound of the civilian's voice. What verification? Hale said. The civilian looked at Solis. Solis looked at Claire, and for a fraction of a second, before anyone said a word, the entire room held its breath in the specific way of a space that understood something irrevocable was about to enter it. The civilian's name was Bosworth, and he held the phone out toward Solis with the specific neutrality of someone who understood that the information on the screen was significant, and that it was not his job to determine what happened next with it. Solis took the phone. Read the document. His expression did not change, but his posture shifted in a way that was nearly imperceptible, a slight settling. The kind that came when a person who had been moving fast stopped and allowed themselves to arrive at where they already were. He looked at Claire. Captain Morgan, he said. He used the rank. Not nurse, misuse. Not Ms. the rank. In a room full of people who had been calling her Morgan for 3 hours, the addition of that single word landed with the weight of something that had been absent the entire night. Hale turned from the workstation. Captain, he said it carefully. Not with sarcasm. Not with the edge he'd been carrying since the first time she'd interrupted him. With the tone of someone encountering a word in a context that didn't yet fit his map of the situation. Solis handed the phone to Reyes, who took it without being asked and began the process of distributing what was on it to whoever needed to see it. Then he stood in the center of the trauma bay with his hands at his sides and spoke to the room with the matter-of-fact delivery of a man reading coordinates. Captain Claire Morgan, formerly of the United States Army Special Operations Command, combat medic specialist, attached to a joint operational unit for 4 years before separating from service. Her record includes a classified field action in which she maintained viable medical status on 4 critically wounded personnel for 41 minutes under sustained hostile conditions with improvised equipment and no physician support. He paused. She received a commendation for that action. At her own request, the commendation and the associated record were sealed. Nobody in the room said anything. The 5 patients currently in this bay, Solis continued, represent a second instance in which Captain Morgan has managed critical military casualties under conditions where standard protocol was insufficient and where the people around her did not have the experience or the information to respond correctly. Hale was very still. The difference, Solis said, his voice stayed even, is that this time she was working inside a civilian institution, where the obstruction came from her own chain of command. Obstruction. He used that word deliberately and placed it where it could not be misread. Hale opened his mouth, closed it. I'm not making a legal characterization tonight, Solis said, before Hale could find whatever he was going to say. That is not my function. My function is to ensure the safety of my personnel and to document the conditions of their care. He turned to Bosworth, the civilian with the tablet. Everything from 2210 forward. Bosworth was already recording. Had been, Claire realized, since before Solis had spoken. The tablet wasn't just a communication device. It was documentation equipment. She didn't know exactly when that had started, but the angle of it had been consistent with the trauma bay's main working area for the better part of an hour. She looked at Hale. He was looking at the tablet, at Bosworth. The way the pieces of the evening were reassembling themselves into a shape that was very different from the shape he'd been standing in an hour ago. Garrett, near the entrance, had gone the particular color of someone whose body was responding to stress faster than their mind, was processing the reason for it. Claire turned away from both of them. She went to patient 4, to Reese. He was awake. He'd been awake through most of Solis's statement, she thought, watching from his gurney with eyes that were tired but tracking. She checked his monitor, checked his IV line, checked the portable O2 unit's pressure gauge. You heard that, she said. Not a question. Most of it. His voice was rough, but steadier than it had been an hour ago. Part about the commendation. I didn't want it public. I know, a pause. I didn't tell them who you were. I only told them where to find you. She looked at him. There was something in that distinction that she understood the specific ethic of people who'd operated in contexts where information was currency and you spent it carefully. He'd pointed them at her without exposing her. He'd given her the chance to be found rather than revealed. You could have told them before tonight, she said. You left for a reason. He held her gaze. Wasn't my reason to give away. She checked his numbers one more time, held for a moment at his bedside without saying anything further, because some things didn't need the elaboration. Then she went back to work. The next hour operated on 2 simultaneous tracks, and Claire ran both of them. The first track was medical. All 5 patients needed continued monitoring against the modified protocol, and the protocol's sequencing was specific enough that deviation had measurable consequences. She moved between gurneys with alongside her for the first 30 minutes, walking him through the reasoning behind each adjustment, not because she needed help, but because he was going to be managing these patients when she couldn't be present, and he needed to understand the logic, not just the steps. He was a fast learner. He asked good questions, the kind that came from genuine engagement rather than performance, completely, and without condescension, and he absorbed them in the way that people absorbed things, when they understood that the information was real and the stakes were real. Nkosi's refined compound analysis came through at the 90-minute mark. Specific subfamily confirmed. The clearance timeline updated. Claire cross-referenced it against the modified protocol and found 2 adjustments to make in the supportive care sequencing for patients 3 and 5, both of which she flagged to Hale. Hale implemented both adjustments without comment. He had been implementing her recommendations for the past hour without comment. Each time she brought him a clinical observation or a protocol-based recommendation, he read it, processed it, and acted on it. He did not thank her. He did not acknowledge the pattern. But he also did not redirect her or question her scope or tell her to return to documentation. She didn't need him to say anything. She needed him to keep doing what he was doing, because patients 3 and 5 were still in a range where a wrong call in either direction had consequences. The second track was institutional, and it moved faster than she would have preferred. Bosworth and the second civilian, who introduced himself to Dolores as Marks, from the hospital's external compliance liaison, a title that Claire had never heard attached to a real position, but which clearly meant something to the administrative structure of Cascade Valley, moved through the trauma bay with a systematic thoroughness that was not disruptive, but was completely relentless. They reviewed documentation. They reviewed the security footage from the trauma bay entrance and the nursing station. They spoke with Dolores, with Tanner, with the respiratory therapist, whose name was Gutierrez. Spoke briefly with Nkosi. They did not speak with Hale yet. Specific sequencing choice, and Claire recognized it for what it was. They were building the record before they talked to the person the record was about, so that his account couldn't shape what had already been established. Garrett, at some point in this hour, was asked to remain in the trauma bay by Marks. Not physically. Mark simply told him, in a quiet and unremarkable tone, that he'd need a statement before the end of the night, and it would be helpful if he stayed available. Garrett said yes. He sat down in a chair near the documentation station and did not move much after that. She was at patient 1 station, the patient who'd had the longest exposure window and was paradoxically doing the best tonight. Because his triage had been straightforward and his vasopressor exposure had been limited when Dolores came to stand beside her. Marks asked me about the transport paperwork, Dolores said. What did you tell him? What I know. That it came in with the patients, that the environmental flag was in the field notation, and that I'm the one who pulled it for you. She paused. I also told him about the oxygen manifold, the maintenance log, fact that you flagged it twice before anyone responded. Claire made a notation in patient 1's chart. You didn't have to include that. I included what happened. Dolores's voice was the same steady tone it always was. There was a brief silence. The field notation about chemical exposure, Claire said. It was in the transport paperwork when the patients arrived. Someone should have acted on it in intake. Yes. Dolores said it simply, without drama. Someone should have. Claire finished the notation, moved to the next patient. At the 2-hour mark after Solis's arrival, Marks asked Hale to step out of the trauma bay. He asked it the way people asked things when the asking was a formality, and the thing was going to happen regardless. Hale went. His face had the set quality of a person who had been rehearsing something internally for the past hour, and was not confident in the rehearsal. Garrett watched Hale leave. Then Marks came back in and sat down across from Garrett. Claire didn't watch that conversation. She was at patient 5 station, where the numbers had climbed to 96, and were holding, and she had the specific job of monitoring his respiratory function over the next 20 minutes, while the modified protocol's final adjustment took hold. She kept her attention on her patient, and let the institutional machinery do what institutional machinery did when it had been properly loaded. But she heard fragments. She heard Garrett's voice, lower than usual. She heard specific words, Hale's instruction, redirected per attending, not my decision, and she heard Marks's voice, asking the same question twice in different forms, which was how you found the edge of a person's account. She heard Garrett's account of the evening begin with confidence and develop hesitation and arrive. Somewhere in the middle portion, quiet of someone who had realized that the version they'd prepared was not going to hold up against that had already been documented. She focused on patient 5, 96, 97. She let herself feel that briefly, the number moving in the right direction. Culmination of everything from the moment the ambulance doors had opened, every dismissed observation, every redirected warning, every minute of working the situation in from the margins of a room that hadn't wanted her at its center. All of it in that number, 97 and holding. Tanner came to stand beside her after a while. He looked at the monitor, looked at Claire. The differential you built, he said. The one on workstation 3. What about it? I read the whole thing while Marks was talking to Garrett. He paused. It's the most complete parallel clinical assessment I've ever seen built without physician access. He was quiet for a moment, built it in real time, while Hale was actively limiting what you could do. She looked at patient 5's numbers. I built it because I needed a record. I know. He paused again. He had the quality of someone who wanted to say something and was assembling the right form for it. I should have pushed harder when you told me about patient 3. The abdominal guarding. You pushed enough. He went to surgery 20 minutes later than he should have. She looked at Tanner. He was not self-flagellating. He was doing the specific thing that good clinicians did when they reconstructed a sequence and found the places where they'd been slow. It was uncomfortable, and it was necessary, and it was one of the things that separated the people who got better from the people who didn't. 20 minutes and he made it, she said. File the debrief. Adjust the next case. That's how it works. He nodded. It wasn't absolution, it was instruction. She meant it as both. Hale came back into the trauma bay 45 minutes after he'd left. Something had changed about the way he moved through the space. He came in the way people entered rooms when they had just been told something they already knew at some level and had been hoping not to hear stated plainly. He went to the documentation station. He pulled up the system and stood looking at it for a moment. Then he came to patient 5 station. Claire was still there, running the last monitoring cycle. She didn't stop what she was doing when he approached. The intake report, Hale said. She made a notation, said nothing. The environmental exposure notation from the transport team was flagged in the field paperwork. When patients are transferred with a field notation recommending toxicology review, the intake processing is supposed to generate an automatic referral. His voice was flat, in the specific way of a person reading from a document they had just been shown. The referral wasn't generated. Marks found the reason. The intake nurse on duty tonight checked a wrong status field during processing. The flag was entered but categorized incorrectly. He paused, which means the toxicology referral that should have been automatic was never sent. She looked at him. That's not on you, he said. The intake error happened before you, or I saw the patients. I know, she said. But when you came to me at 22:10, he said, and here his voice did a specific thing. It contracted slightly. The way voices did when the person using it was removing the space around a difficult fact, so they had to look at it. Directly, you were already reading the consequence of that error, and I characterized it as overreach. The room around them had gone to a background register. Tanner was across the bay. Dolores was at the charge desk. Civilians were in the corridor. Nkosisi was packing her analysis equipment. None of them were close enough to hear this exchange clearly, and all of them were specifically not looking in this direction. Yes, Claire said. Patient 2's cardiac risk window was approximately 40 minutes, Hale said, based on the vasopressor dose and the interaction threshold Nkosi gave us. We'd had the modified protocol at 22:10. Don't. She kept her voice even. Don't run that calculation right now. Not here. He stopped. She turned to look at him fully. Patient 2 is alive. Patient 4 is stable. All 5 are going to make it. She held his gaze. Calculation you're running will be there tomorrow and the week after. You'll run it in the debrief and the formal review, and probably at 3 in the morning on a Tuesday for the next 5 years. But right now, you are still the attending in this room, and there are 5 patients who need the rest of this night managed correctly. He looked at her for a long moment. I judged you before I knew you, he said. Came out without the architecture around it, without the framing of a formal acknowledgement or the buffer of professional language. Just that sentence, plain in the specific tone of something that had been sitting somewhere for several hours and had finally been said. She had an answer for it. Had been building one all night, probably, in the part of her mind that ran parallel to the clinical work and processed the thing underneath. What came out was different from what she'd expected. You judge the badge, she said, not the patient. He held her gaze for one more moment. Then he turned back to the room and picked up the nearest chart, because there was still work to do, and they both understood that. 2 hours later, the trauma bay had reached the specific state of late-night clinical stability that was less resolution than exhale monitors, consistent, patient sedated or resting, the acute phase fully passed. Nkosi had delivered her complete analysis to both Solis and the hospital's overnight administration. Solis had transmitted the formal field report. Marks had collected documentation from 7 hospital staff members and had left with Bosworth for what he described as a preliminary review session with the hospital's risk management office, which was located on the 4th floor, and was about to have a very long night. Garrett had been asked to submit to a formal statement review in the morning. He'd been told to keep himself available. He'd left the trauma bay 30 minutes ago, with the posture of someone who understood that available and free were not currently the same thing. Reyes's, the woman in uniform who'd been managing communications since Solis's team arrived, found Claire at the documentation station at approximately 2 in the morning. She sat down in the chair that Marks had vacated and put a folder on the desk between them without opening it. There's going to be a formal naval inquiry into the treatment of the unit, Reyes said. But standard procedure when personnel receive care at a civilian facility during an active medical situation involving a classified exposure. She paused. You'll be asked to provide testimony. I'll provide it. Your sealed record will be part of the case file. Can't be resealed once it's been pulled into a formal inquiry. Claire looked at the folder on the desk. I know. I want to make sure you understand that. Specifically, Reyes said. Commendation, the classified extraction, your service history, it's going to be in the formal record. I understand. Reyes was quiet for a moment. She had the look of someone who had expected more resistance and was recalibrating. Why did you have it sealed in the first place? Claire considered the question. was a reasonable one, and she'd answered it to herself many times in the 9 years since she'd made the request. The answer had changed somewhat depending on which year she was in, but the core of it had stayed consistent. "Because I didn't want it to be the reason people listened to me," she said. "I wanted the work to be enough." Reyes absorbed that. And tonight? Tonight I needed both. She looked at the trauma bay, at the 5 gurneys, at the monitors holding steady in the low-lit quiet. The work got us through the first 90 minutes. The record got us through the rest. Reyes picked up the folder, started to stand, then stopped. "Sergeant Reese asked about you," she said. "Before we came down to the bay," he said in Zah again. "I'm quoting that if they ended up at Cascade Valley and she was there, we should watch the room, not the monitors, because the room would tell us where the real problem was." Claire looked at the bay. "He was right," she said. Reyes stood. "The inquiry will be in contact within 72 hours. She went toward the doors. Claire sat at the documentation station and looked at the case files for all 5 patients, laid open across the workstation. She began the formal completion of the night's records, not the parallel differential she'd built for her own purposes, but the complete clinical record that would follow these 5 men out of this hospital and into their recovery, and eventually into whatever naval medical file served as the permanent account of tonight. She wrote carefully and completely. She was 2/3 through the records when Dolores appeared at her shoulder, with coffee that was marginally less terrible than the cup he had to touch 6 hours ago. "Marks is upstairs," Dolores said. He asked Kessler to pull the security footage from the trauma bay entrance, the nursing station, and the secondary storage corridor. Kessler was the night administrator. Claire looked up from the records. "All of it? From 1800 to present." Dolores set the coffee down. He specifically requested the segment from 2210 to 2240. The window during which Claire had flagged the environmental concern, been redirected twice, had the syringe intervention at patient 2's gurney, initiated the toxicology call, and been threatened with formal removal from the floor. All of it on camera. All of it time-stamped. She looked at Dolores. "He also pulled the oxygen system maintenance log," Dolores said. "The one with the pressure readings," he asked. "Who had flagged it and when?" "There'll be a record of my calls to maintenance." 2 calls, timed 23 minutes apart, Dolores confirmed. "Both logged." She paused. "And Kessler pulled Hale's formal refusal of the toxicology consult. Nkosi's documentation of that refusal, and the intake processing error, the one that killed the automatic referral. The shape of what was being assembled upstairs clarified. Not just an incident report. A chain. Intake error creates the gap. Gap is identified by nursing staff. Nursing staff is overruled. Overruling is documented. Outcome is recorded. Chain is complete." "Where's Garrett right now?" Claire asked. "He went home 20 minutes ago. Marks asked him not to go far." Dolores paused. "He didn't look good when he left." Claire turned back to the records. There was still an hour of documentation ahead of her, and it needed to be done before shift change. She was finishing patient 3's record when the bay's secondary entrance opened, and one of the overnight admin staff came in with a printed message, slip the old-fashioned kind, which was only used for communications that someone wanted to be certain were received in physical form. The slip was addressed to her. She opened it. It was from the hospital's chief medical officer, a woman named Dr. Sylvia Tran, who had not been in the building tonight and was apparently being briefed remotely on the situation as it developed. The message was 3 sentences. "Nurse Morgan, I've been brought up to speed on the events of this evening. I'd like to meet with you at your earliest convenience, tomorrow if possible. Please consider yourself cleared of any conduct concerns that may have been filed or noted during this shift." Claire folded the message slip. She looked at the fold line, looked at the patient records on the screen, looked at the 5 gurneys with their 5 monitors, all of them holding. She put the message slip in her pocket. She finished the records. Shift change. She gave a thorough handoff to the incoming nurse, a methodical woman named Sorensen, who asked careful questions and took complete notes, and who, near the end of the handoff, said quietly, "I heard what happened tonight. Whole floor has." Claire closed the last patient file. "Make sure they know the modified protocol runs through 72 hours post-admission. Don't let anyone swap to standard management before Nkosi signs off." "Understood." Sorensen paused. "That's not what I meant." "I know what you meant." Claire gathered her things. Make sure Reese gets his auscultation checks every 4 hours. His left lung is going to be the last thing to clear. She walked out of the trauma bay. She was in the corridor halfway to the locker room when she stopped. She stopped because something had occurred to her that she hadn't thought about until this moment, something in the construction of the night's events that she'd been too busy managing to examine from the outside. The intake processing error, the wrong status field, flag that had been entered but miscategorized. She'd taken Hale's account of it at face value, because the explanation was plausible, and because the night had been moving fast, and because she'd been focused on the patients. But she stood in the corridor now and thought about it with the specific attention it hadn't received at the time. The transport paperwork had included the environmental flag clearly and explicitly. The intake nurse had processed the patients on arrival. The flag had been entered into the system and then miscategorized, not missed, not overlooked, but entered, and then filed in a way that suppressed the automatic referral. She thought about Garrett. Garrett, who had been at the intake station when the patients arrived. Garrett, who had taken the transport paperwork from the paramedic team. Garrett, who had been the one to tell Hale that she'd left her assigned documentation post twice, with the helpful precision of someone who wanted those observations to land. Garrett, who had disappeared from the trauma bay for a significant period during the Navy commander's arrival, had come back to find the situation completely transformed. She thought about the way intake processing worked, about who had access to status fields at the intake stage, about the difference between an error made by an intake nurse under pressure and an error made by someone who understood the system well enough to make it look like an intake nurse's error. Stood in the corridor. She took out her phone, opened a message to Marks, whose contact information Reyes had given her 2 hours ago. She typed one sentence. The intake processing error, did you confirm it was made by the intake nurse, or only that it occurred at the intake stage? Sent it. She put her phone in her pocket and stood in the corridor for another moment, in the specific stillness of someone who has just identified a question that changes the weight of every answer that came before it. Then her phone buzzed. She looked at the screen. Marks's reply was 4 words. We're looking at that. She stood in the corridor for another 30 seconds after Marks's reply came through, holding the phone and looking at those 4 words in the way you looked at something that confirmed a suspicion you'd hoped was wrong. We're looking at that. Not that was the intake nurse. Not yes, we traced it. It was a processing error. 4 words that meant the question she'd asked had already been asked internally by people with more access than she had, and that the answer was still open. Phone away, and went to the locker room. She changed out of her scrubs, slowly, with the specific physical deliberateness of a person whose body had been running on concentrated attention for 8 hours and was now in the process of remembering it had limits. Her hands were steady, but her shoulders ached in a way that told her she'd been holding them higher than usual. For most of the night, the posture of someone bracing for the next thing, held so long it had become invisible until it stopped. She sat on the bench in front of her locker for a moment before she stood up to leave, thought about Garrett, about the intake stage, about the specific architecture of what had happened tonight and who had been in a position to shape it. Then she stood up, put her bag over her shoulder, and went home. She slept 4 hours, which was not enough and was what she had. When she woke, there were 2 missed calls from a number she didn't recognize, one message from Reyes confirming the naval inquiry timeline, and a voicemail from Dr. Sylvia Tran's office asking her to come in at noon. It was 9:47 in the morning. She made coffee, stood at her kitchen window, looking at the water, which was gray and flat and honest, in the way that the Puget Sound was on overcast mornings. She drank the coffee and thought about Reese, about the way his hand had felt on her wrist in the trauma bay, the specific weight of it, the deliberateness, and about the phrase he'd used that had unlocked the part of her she'd been very careful to keep locked. Don't let them use the standard sequence. 9 years of distance. 9 years of building a life in which she was a nurse, and that was the whole of what she brought into a room. And in one night, it had all come apart at the seams, not in a way that destroyed anything, but in the way that old careful structures came apart when they were no longer necessary, when what they'd been protecting had already survived. She finished the coffee, got dressed, went back to the hospital. Dr. Sylvia Tran's office was on the 5th floor, which Claire had been to exactly twice in 3 years, both times for routine administrative reviews that had lasted 15 minutes and produced no consequences. The office looked like the office of a person who had spent 20 years making difficult decisions and had stopped decorating. Around year 12, functional, organized, with the specific absence of personal items that came not from coldness, but from having learned that the work was the thing. Tran was in her early 60s with the kind of face that had been sharp and was now precise, which was a different quality. She stood when Claire entered and extended her hand, which told Claire something about how this meeting had been calibrated before it began. "Sit down, please." Tran gestured to the chair across from her desk and sat herself. She had a folder open in front of her, but she didn't look at it. She looked at Claire. "I've spent the last 4 hours reading everything that came out of last night. The documentation, the security footage, the maintenance logs, Nkosi's analysis, and Commander Solis's preliminary field report." She paused. "I want to start by saying that what you did last night, specifically and without qualification, prevented multiple deaths," Claire said. "The patients aren't fully cleared yet. No. But Nkosi put the survival probability of patients 2 and 4 without your intervention at under 40%, given the vasopressor interaction and the cardiac window." Tran said it plainly. "I'm not interested in hedging that." Claire looked at the folder on the desk. "What does the security footage show?" Tran glanced down briefly. "It shows Dr. Hale redirecting you at 22:10, 22:23, and 22:31. It shows Dr. Garrett's position at the intake station during the processing of the transport paperwork." She paused on that last sentence in the way that people paused when a sentence carried more weight than its construction suggested. "And it shows the intake terminal that processed the environmental flag during patient arrival. Who used it?" Tran looked at her. "Marx's team pulled the system access logs this morning. The intake nurse, her name is Paola Ruiz. She's been on staff for 6 years. She has a clean record, processed the patients in the correct sequence, and entered the environmental flag correctly. The flag was then accessed from the same terminal approximately 4 minutes later, and the status field was manually changed." Tran paused. Ruiz had gone to retrieve IV supplies. She was away from the terminal for 11 minutes. Claire was quiet. Dr. Garrett's access card was used to log into the terminal during that window, Tran said. "The system log is time-stamped. The corridor last night. The specific posture of Garrett when he'd returned to the trauma bay after Solis's arrival. The helpful precision with which he'd told Hale about Claire's movements. The way he'd disappeared when the Navy commander walked in. He knew what was in the transport paperwork," Claire said. "The working conclusion, yes." Tran's voice stayed level. "The naval inquiry is treating it as interference with military medical transport, which is a federal matter, not a hospital matter." She paused. "That doesn't mean the hospital matter isn't also significant. What happens to him? His hospital privileges are suspended pending the inquiry. Federal finding goes where Marx thinks it's going. His medical license will be subject to a board review." Tran looked at Claire directly. "He's done practicing medicine here. That's already decided." Claire thought about Garrett. About the particular species of arrogance that didn't operate from confidence but from fear, the fear of being outpaced, of being made visible next to someone who did the thing better, of having the room's attention go somewhere it wasn't supposed to go. That kind of arrogance didn't usually end up as malice, but it had last night in a system access log at an intake terminal while Paola Ruiz was getting IV supplies, and it had nearly cost 5 people their lives. "And Hale," she said. Tran was quiet for a moment. "Dr. Hale submitted a formal incident report this morning." Self-reported. She let that sit briefly. "He documented his own decision to decline the toxicology consult and his characterization of your observations as outside nursing scope. He described the medication interaction near miss at patient 2's station and attributed the identification of the error to you." She paused. "He didn't have to do that. The security footage would have established it anyway, but he put it in writing before anyone asked him to." Claire looked at the window behind Tran's desk. "Gray sky still. He'll face a peer review," Tran said. "It's mandatory given the clinical outcome. The review board will determine the scope of any consequence. Can't predict what they'll decide." She paused. "But he's cooperating fully. That matters. It was not a clean outcome for Hale, and it was not a vindicated one. It was the outcome of a person who had been wrong in ways that had consequences, and who had, at some point in the small hours of the morning, decided to be honest about it." Claire didn't have a strong feeling about what happened to him after that. Peer review would do what peer reviews were designed to do, and the result would be what it would be. I'm here to talk about you, Tran said. Not them. Claire looked at her. The conduct notifications that were filed against you during the shift, 3 separate entries logged by Dr. Hale citing scope violations. I'm voiding them as of this morning. They'll be removed from your personnel file entirely. Tran kept her eyes on Claire's. I'm also recommending to the board that your response last night be formally recognized in your record. Not as a commendation necessarily, that's their decision, but as a documented exemplary clinical response to an evolving emergency. You don't need to do that. I know I don't need to. Tran's voice was measured but not cold. I'm doing it because it's accurate, and because accuracy in personnel records matters. Spent 9 years in this institution, well 3 here, but the whole of your nursing career doing work. Consistently excellent and consistently underattributed. I'm not in a position to correct the whole of that, but I can correct what happened last night. Claire looked at the folder, at the plain surface of Tran's desk, the gray window. She had wanted the work to be enough. That was the thing she'd told Reyes last night, the reason the record had been sealed. The reason she'd spent 9 years being a nurse and nothing else when she walked through hospital doors. She'd wanted to prove that the work, done well, was sufficient. That you didn't need the credential of a classified past to justify the space you occupied. And the work had been enough last night. Up until the moment the institutional machinery had made it insufficient. Up until the point where being right about 5 dying patients wasn't enough to override being the nurse the attending had already decided not to hear. She understood sitting in Tran's office in the gray morning light that both things were true at once. The work was enough, and sometimes the record was the only thing that could protect the work from the people who decided not to see it. She could hold both of those without resolving them. That was where the last 9 years had been taking her, maybe, without her knowing it. Thank you, she said. Tran nodded once. There's one more thing. She reached into the folder and removed a single sheet. Commander Solis submitted a formal request to the hospital this morning. He's asking that you be designated as the primary care liaison for the unit during the remainder of their recovery here. Typically, that designation goes to the attending, but Solis has the authority to request a specific individual under the Military Medical Coordination Protocol, and he's exercising it. She slid the sheet across the desk. It would mean an adjusted schedule for the next 3 to 4 weeks, coordinating with Nkosi, attending the naval inquiry briefings, managing the modified protocol for all 5 patients through to clearance. Claire looked at the sheet. It's not a promotion, Tran said. It's not a desk job or an administrative role. You'd be on the floor, managing those patients. I know what it is, Claire said. You want it? She looked at the sheet for a moment longer. Then she picked it up. Yes, she said. The formal naval inquiry briefing took place 8 days later in a conference room on the hospital's 4th floor that had been temporarily reclassified for secure use. Claire sat at a long table with Solis on one side and Nkosi on the other, and a row of naval officers and legal personnel across from them. She gave testimony for 2.5 hours. She was specific, sequential, and complete, and she did not editorialize and did not omit. When it was over, the inquiry's lead officer, a woman named Commander Paige Whitfield, who had the specific quality of someone who had conducted enough of these to know exactly what she was looking at, thanked Claire for her account. The record will reflect, Whitfield said, that the treating nurse identified the exposure pattern, initiated the appropriate referral chain, was systematically obstructed in doing so, and continued to manage patient care from outside formal authority until the correct protocol could be established. She looked at Claire across the table. The record will also reflect that 4 of the 5 patients would likely have experienced fatal cardiac events without the intervention you provided. Claire looked at the table, looked at Whitfield. 5, she said. All 5 were in the window. Whitfield held her gaze. 5, she confirmed. The inquiry concluded, with formal findings delivered 6 days after that. Garrett's interference with the intake record was referred to federal prosecutors. His medical license was suspended pending the proceeding. The hospital's peer review board completed its assessment of Hale's conduct and issued a formal censure. The specific language was failure to appropriately evaluate clinical observations from qualified nursing staff, resulting in delayed critical intervention along with a mandatory remediation program and a period of supervised practice. He was not removed from the hospital. That was the board's decision, and they had their reasons. And Claire didn't agree with the scope of it and didn't have to. What she had was the record. What she had was the voided conduct notifications, and the formal clinical recognition, and the designation as primary care liaison, and the 5 patients on the modified protocol who were day by day and number by number getting better. 3 weeks after the night the ambulances came through the bay doors, Sergeant Dale Reese sat up in his hospital bed for the first time without assistance. He did it carefully. His left lung was the last thing to clear, as she'd told Sorensen it would be, and the effort of sitting upright still cost him something visible. But he sat up. He looked at the window. He looked at the room with the deliberate orientation of a man re-establishing his coordinates. Claire was doing his morning assessment when it happened. She had the pulse oximeter in her hand, and she stopped what she was doing and let him have the moment, because some things were not clinical events and didn't need to be treated as one. After a while, he said, "You're still here. Someone has to do your auscultation checks every 4 hours." Could have handed that off. I could have. He looked at her. Why didn't you? She clipped the oximeter to his finger and watched the number settle. 98. She wrote it down. Because you asked for the nurse with the old watch, she said. Seemed like the least I could do was finish the job. Something moved across his face. Not quite a smile, it was too worn around the edges for a smile. Too aware of everything it had cost to be sitting here having this conversation. But it was in the same neighborhood. 11 years ago, he said. 11 years. You look younger then. You looked in better shape, she said. He made a sound that was close enough to a laugh that they both counted it. Then he was quiet for a moment, looking at the window again. The others are okay, he said. Patient 2 was discharged yesterday. 1 and 3 are cleared to transfer to the Naval Medical Facility tomorrow. You and patient 5 have another week, maybe 10 days. She paused. He's doing well. Reese nodded, absorbed that the way he absorbed things fully, without a lot of visible processing on the surface. You're going to keep being a nurse, he said. It wasn't quite a question. That's the plan. Not a doctor. Not an administrator. No. He looked at her. You're good at it. I know, she said. Not with arrogance. With the specific grounded certainty of a person who has spent a long time doing a thing and has finished needing to be told it by anyone else. He held her gaze for a moment. Then he looked at the watch on her wrist, the old one, the military-issue one, with the scratched crystal and the worn strap that she'd had since her second deployment. She'd stopped pulling her sleeve over it 2 weeks ago. She wasn't sure exactly when. It had just stopped being a thing she did. You're not hiding it anymore, he said. No, she said. He looked at the watch for another moment. Good. Finished the assessment. Made her notations. Moved toward the door. Morgan, he said. She stopped. Thank you. He said it plainly without the weight of ceremony, the way people said it, when they meant it exactly at face value. 11 years ago and now, both times. She looked at him. The window behind him, with the pale November light coming through. At the monitor beside him, with its steady, unhurried numbers. Rest, she said. You've got auscultation in 4 hours. She went out into the corridor. The floor was its normal morning self, the specific controlled energy of a hospital coming fully awake, nurses at stations, residents moving between rooms, the ambient noise of a system that never fully stopped and never quite fully started. She'd worked this floor for 3 years. She knew its rhythms the way you knew the rhythms of any place you'd given significant time, to the way certain corridors were louder at certain hours, the way the light changed at the nursing station between 7 and 8 a.m., the way Dolores made coffee at the same time every morning, and the coffee was always exactly as bad as it had been the day before. She walked past the central nursing station, and Dolores, without looking up from what she was writing, said, "Tanner's looking for you." Something about the modified protocol discharge criteria. Find him. She kept walking. At the end of the corridor, there was a window that looked out over the bay. She stopped there for a moment, not because she needed to, but because she was between the thing she'd just done and the next thing she needed to do, and the space between those two things was hers. Water was still gray this morning. It was usually gray this time of year. She'd stopped finding that depressing somewhere in the second winter she'd lived here, and had arrived at the opinion that gray was an honest color. It didn't perform anything, didn't commit to a mood that the day might not sustain. It was just the light that was available. She thought about what had changed and what hadn't. She was still a nurse. She was going to keep being a nurse. The work was the same work it had been the morning. Before the ambulances came assessment, intervention, documentation, the particular sustained attention of managing systems that wanted to fail and keeping them functioning. She hadn't become something different. What had changed was that the room now knew what she was, and she had stopped spending energy on making sure it didn't. That was not a small thing. It turned out it had been a significant amount of energy across 9 years, and she hadn't fully understood the cost of it until she felt the difference. She thought about Garrett, about what fear of being outpaced looked like when it stopped being a private feeling and started making choices. She didn't have a clean emotion about him. It was a compound thing, the way most things were when the harm was real, and the person causing it was also comprehensible. He had done something that could have killed 5 people, and he had done it from a place she recognized as human, even while the act itself was not defensible. She hoped the federal proceeding went exactly as far as the evidence warranted. She hoped it was uncomfortable and public and precise. That was what accountability looked like, not satisfying. Exactly, but correct. Thought about Hale. About the self-reported incident form. About the specific difficulty of being wrong in ways you can't take back and deciding to document it anyway. She didn't like him, particularly. But she had spent the last 3 weeks working in a room where he was also working, and she had watched him implement her recommendations without challenge and ask clinical questions that were genuine rather than territorial. And she had come to the conclusion that whatever he was working through internally was, at least, moving in a direction that might produce something useful. She didn't owe him forgiveness. She wasn't interested in performing it, but she wasn't carrying the weight of him either. And that turned out to be a lighter way to occupy the same professional space. She thought about her sealed record, which was now unsealed, which was now part of a formal naval inquiry file, and a hospital personnel record, and a formal clinical recognition document that would follow her for the rest of her career. She had wanted to control the terms of that disclosure. She had not gotten to. The terms had been the night itself, 5 gurneys, 1 failing oxygen manifold, a commander in dress uniform asking the right nurse the right questions at the right time. She had spent 9 years protecting the record from becoming the reason people listened to her. What she understood now, in the gray morning light at the end of the corridor, was that the record was never the reason. The reason was the work. The record just made it harder for certain people to pretend the work hadn't happened. Those were not the same thing. She'd been conflating them for 9 years, and the conflation had cost her something. She couldn't fully name some version of the ease that came with not having to fight for the right to be seen accurately. She had done the fighting anyway, every night, because the work required it. But she'd done it while also carrying the additional weight of the concealment, and the concealment was the part that had been optional all along. She was done carrying optional weight. The window showed her the gray water and the pale sky and the ordinary morning of a city that didn't know what had happened in this building 3 weeks ago and would never know most of it. Fine. That was the nature of this kind of work. It happened in rooms that most people never entered, on timelines that most people never saw, for outcomes that looked from the outside like nothing remarkable. Patient went home. 5 men flew back to their base. A nurse went to work the next morning. That was the whole visible shape of it. The invisible shape was something else. The invisible shape was every decision made in the minutes before the monitors caught up. Every observation documented on a workstation that nobody had asked for. Every redirect absorbed without retreating. Every moment of holding the clinical picture clearly while someone with more institutional authority told her she wasn't qualified to have it. That shape didn't need an audience. It had happened. The 5 men were alive because it had happened. That was the only certification that mattered. She pushed off from the window. Tanner was at the nursing station, waiting with a question about the discharge criteria that turned out to be specific and reasonable and took 4 minutes to resolve. She resolved it. She moved to the next patient, and the one after that, and the one after that. Checked her notes. She updated records. She stopped at patient 5's room and ran his morning assessment and recorded 98, same as Reese, steady, both of them holding. At mid-morning, she passed the clock at the end of the corridor, the digital one that had been showing 11:42 when the ambulances came through the bay doors 3 weeks ago. She passed it without stopping, the way she passed it every shift, the way she would pass it tomorrow, and the shift after that. She was pulling her sleeve up to check the time on her watch, the old one, the scratched one, the one that had been under her cuff for 9 years, and was now just on her wrist when Dolores appeared at her shoulder. "You're checking the watch now," Dolores observed, "not the clock. The clock's been running 40 seconds fast since September." Dolores looked at the clock, looked at the watch. Huh, she considered this. "You going to report it?" "Already filed the maintenance request," Claire said. 3 weeks ago. Dolores made the specific sound that she made when something landed slightly to the left of where she expected it. Then she walked away, because there were 14 other things requiring her attention, and the clock had been running 40 seconds fast for 2 months, and it would get fixed when maintenance got to it. Claire went down the corridor to her next patient. She had told Tran she would take the designation. She had meant it completely. 3 to 4 weeks of coordinating the modified protocol, attending the naval inquiry briefings, managing the 5 men through to clearance. After that, the designation would end, and she would still be a nurse on this floor, on the rotation she'd been on, doing the work she'd been doing. No change in title, no corner office, no formal position that named what had happened on that Tuesday night and established her differently in the hierarchy. She had thought about this. She had considered the offers that existed in the space between what had happened and what might be possible. There had been one, brief and carefully phrased, from Tran in a follow-up conversation, suggesting that the hospital would be open to discussing a clinical education role, a position that would let her share what she knew more formally, train residents, sit in on protocol reviews. She had thought about it for 2 days. Then she had said no, not because she was angry, not because she didn't want to contribute more broadly, or because she lacked the experience to do it well, but because what she was a nurse, and a nurse was who she needed to remain, and the floor was where the patients were, and the patients were where the work was, and she was not finished with the work. She understood that this was a choice some people would find baffling. She understood that it looked, from the outside, like leaving something on the table. What she knew from the inside was that the floor was not a stepping stone. It was the destination. The work done at the bedside was not the lesser version of some more significant clinical contribution somewhere above it. It was the thing itself. It was the shape that mattered. She had known that for a long time. The last 3 weeks had not taught her that. They had simply made it visible to anyone who was paying attention. She stopped outside room 7. This was not one of the SEAL patients' rooms. This was an overnight admission, a woman in her 50s named Evelyn Marsh, admitted for a respiratory complication, following an outpatient procedure, whose chart Claire had read that morning, and whose numbers she was going to check now because they had been in a range she wanted to watch. She pushed open the door. Evelyn Marsh was awake, looking at the ceiling with the particular alertness of someone who had slept poorly and was now examining the available surfaces. She looked at Claire when she came in. "Good morning," Claire said. "Is it?" Marsh's voice was dry and not unkind. "I've been awake since 4. How's your breathing?" "Better than last night." A pause. "Worse than it should be. Let me check." Claire moved to the side of the bed, pulled the stethoscope from her neck, warmed the chest piece. "Breathe in for me," Marsh breathed. Claire listened left side, right side. The careful systematic listening that she had done thousands of times, on thousands of patients in 17 years of nursing, civilian hospitals, and in field conditions, and in every configuration of insufficient resource and high stakes that the work had produced. She listened the way she always listened, completely. The left side was slightly diminished, not acutely, not alarmingly, but enough. "I'm going to order a repeat chest X-ray," Claire said. "Just to be sure." Marsh looked at her. "Is that the nurse version of 'I noticed something, but I'm not going to tell you what it is'?" "It's the version where I want a picture before I speculate," Claire said. "I'll have the result by noon." Marsh looked at the ceiling. "Fine." Claire made the notation, put in the X-ray order, wrote the time. "You were here last night," Marsh said. Late. I saw you in the corridor. Long shift. You work a lot of them? Most nurses do. She capped her pen. Rest if you can. I'll be back with the result. She went back into the corridor. She had 11 more patients on her morning round. She had a protocol coordination call with Nkosi at 11. She had the auscultation checks on Reese and patient 5 at 10 and again at 1400. She had the X-ray result to review for Marsh at noon, and whatever that produced, she would handle when it produced it. She walked down the corridor with the stethoscope around her neck and the scratched watch on her wrist and the 11 patients and the protocol call and the X-ray waiting at the end of it. And she was not carrying anything else. Just the work. The work done clearly, with both hands, with everything she had. It had always been enough. The proof was in every patient who'd left this floor alive. In 5 monitors, holding steady in 5 rooms down the hall. In the particular way, the gray morning light came through the corridor windows and made ordinary things look like what they actually were. She rounded the corner to her next patient. She started the clock.